Okay, so good afternoon, everybody. It's my proud privilege to introduce our speaker for today. In fact, I've known Prakash for more than three and a half decades in various capacities. So, Prakash is someone who's been extraordinarily helpful to the medical diaspora of India over many years, and it's wonderful to have him with us. He belongs to the batch of 1985 from CMC VELLORE. He's currently the clinical lead at, which is basically head of the Department of Endocrinology at the Aberdeen Royal Infirmary in Scotland, which is the oldest medical college in Europe, some 600 years old or something of that sort. He's been member of the executive committee of the British Thyroid Association and served as various members of various positions in that particular committee for a duration of 8 years. He was on the editorial board of the journal Clinical Endocrinology and has been a clinical investigator for a number of endocrine and diabetes trials over the years. He has a special interest in isotope investigation of pituitary tumors and is currently in charge of this one of two centers in the United Kingdom in setting up the 11C Methionine PET CT scan for imaging of pituitary adenomas and covers for the whole of Scotland for this particular project. So this is an area which we have virtually no expertise in India at this particular point of time, and Prakash will be enlightening us on this aspect. Over to you, Prakash. Thank you.
Thank you, Niyal. It's always a pleasure to come to VELLORE and to interact with the department. It's a pleasure to meet up with Asha, who I had the pleasure of working with in Aberdeen. She was there 2 years, and she was there when we started doing the first few scans. So she was very useful when we did our initial audit of that. So it's good to be here. So Aberdeen, for those who don't know, is about 2 hours north of Edinburgh by train, and obviously about quite a bit distance from London and Cambridge. The University of Aberdeen is 600 years old, and it's the third oldest university in UK, and actually the first English-speaking university in medicine in the world, because Oxford and Cambridge were in Latin. Should also mention that since this is the centenary year of insulin, I work in what's called the MacLeod building, which is named after J.J.R. MacLeod, who won the Nobel Prize for insulin, who is an Aberdeen graduate and finally retired in Aberdeen and is buried in Aberdeen. So we are so proud to have that link. It's appropriate to talk about giants, and we have this giraffe here. And my case, I'll obviously be focusing on cases. So this is the couple of model giraffes in front of the Royal Aberdeen Children's Hospital, which some of the cases have originated from. And this goes as the MacDem Center, or the J.J.R. MacLeod Center, which is named after our Nobel Prize winning senior. So the next 40 minutes or so, we'll be covering this. My main focus will be acromegaly, because that's the bigger piece of work that we've been doing. I'll talk about PET scan developments, its use in acromegaly, its use in TSHoma, its use in Cushing's disease. It's got other wider uses, but in Aberdeen, these are the ones that we have had personal experience with, and that's what we'll be telling you about. We are also proud to have the first MRI scanner which is used in the world, and that was made in the 1970s by staff in the University of Aberdeen. So we have the Mark I scanner, and the first patient in the world scanned by an MRI was done in this little machine, which is now a museum piece in our corridor in the hospital. And he was in Fraserburgh. For Asha, if you know where Fraserburgh is, yeah, so it is Fraserburgh. So it's a Professor John Mallard, who just died last year, I think, who was a physicist and was pivotal in that. We in UK we have the acromegaly registry, so we have fairly detailed information about all the patients for a period of time. Anyway, most major centers contributed to this. We had Aberdeen had 90 patients in that registry with acromegaly. With that, most were, of course, macroadenomas, 90% of patients were macroadenomas, and 72% remain uncontrolled. This is across UK, just covering all the centers. So let's start with this case. And actually, it's quite special to me because I met this case in 1997 when I went in Aberdeen. So that shows how long I've been in Aberdeen. So I met this guy in 1997, 25 years ago, when he was 8 years old, and he presented with gigantism, much taller, as you can see at his presentation, compared to, way above the 97th centile. His IGF-1 was 2.5 times the upper limit normal. His growth hormone didn't suppress at all. He had a raised prolactin, so initially cabergoline was given, followed by transcranial surgery. And then, given his age, we didn't want to give radiotherapy. And he was probably one of the first children in the world, or first child in the world to get a somatostatin analog. And I actually presented his case in a pituitary meeting in 1998, next year, when we gave him that. So I've been involved with him right from that period of time. Subsequently, he went on to receive pegvisomant as well. And so pretty expensive medications he's been getting for acromegaly. This is his initial MRI, obviously showing a macroadenoma. And the post-surgical MRI showed a reasonable cure, reasonable sort of surgical excision of the tumor. But clearly, his acromegaly was not controlled. As you can see, this temporal profile, his IGF-1 at the beginning. In the blue lines, blue shadowing is this age-related reference range for IGF-1. So not cured after surgery. He was started on octreotide LAR. This is basically 1998. He was 1997-98. He was started on octreotide LAR. The dose was increased to try and get things. We switched him to lanreotide, and then he was on combination pegvisomant and lanreotide for many years thereafter, which actually maintained his control. So he maintained his control, but a pretty expensive maintenance of control, something in the order of 40 lakhs a year. So that's what he was being costing the endocrine drug budget, so to speak. So the current consensus management was published in 2020. Obviously, first line is surgery. If it's not controlled, sometimes cabergoline is used. Most often we use octreotide or a somatostatin agonist, receptor ligand. Not control on that, pegvisomant. So he's already gone down this line. And then the next options are really, do we consider him for surgery or not? And clearly, that is, given his age and other things, we held off that. This is just a snapshot of the residual acromegaly in the UK in a publication by the Birmingham group. So after first-line surgery, about 40 to 65% had biochemical remission, 35 to 60% had persistent acromegaly. And on medical treatment, even then, nearly 30% continued to be inadequately controlled. So we're not achieving, even in the, with second-line options. So second-line options obviously is pegvisomant, radiotherapy, and other combinations. So what about the cost burden? So I've converted this to Indian rupees. So the cost burden of expensive treatments like pituitary is about 27 lakhs a year. Pegvisomant is 54 lakhs a year. LAR, 11 lakhs a year. I don't know if it's cheaper. I'm not sure if you're getting it cheaper in India. This is what we pay. Our NHS prices may be different from your prices. Maybe UK, they may charge more or whatever. I don't know. But these are our prices, the equivalent conversion prices that we get. So the lifetime cost of pharmacotherapy is 41 to 59 times that of transcranial surgery, depending on the medication. So if you're able to achieve a cure by surgery, you save such a lot in the lifetime of the patient. This is again another look at the control rates after first-time surgery versus second-time surgery, overall control rate using different modalities. As you can see, even on reoperation, the microadenoma higher as 70, but macroadenoma cure rate is only around 27%. It's worse, obviously, if it's into the cavernous sinus. And these are factors you take into consideration when considering options. We have to balance surgery with its complications, and the reoperation first time versus the second time, there's a slightly higher risk of CSF leak and meningitis, cranial nerve palsies, but otherwise not a huge amount of difference in some of the other variables. So conventional imaging, as you know, will help us with low volume residual recurrent disease, but it cannot tell us whether it is residual or whether it's an active tumor from that. And particularly small adenomas, you would not be able to say with confidence. Similarly, incident gliomas are pretty common. A large number of folk will have incident gliomas once you scan them. So it's trying to sort it out is where this molecular imaging comes into being. So various targets have been looked at over the past years by different groups. So you have targets at the receptor site, and obviously the SSTR receptors. There is the pentytride and the gallium dotatate. These are things looking at the SSTR receptors. There are D2 receptor things which have been done as well, and I'm not an expert in any of these molecules. I'm not even going to pretend, and if any question, I'll pass on to any nuclear medicine colleague here on that. There is also a corticotrope receptor recently been able to be picked up as well. So there's a gallium CRH receptor, membrane receptor being able to be there. And that might be pretty attractive. It's not obviously widely available, but it will be very attractive for Cushing's as an option. Obviously, targets on metabolism is the FDG PET, and there have been studies looking at it, and they have not really shown that degree of usefulness in the pituitary. And what we are, or rather the Cambridge group, focused on is the peptide synthesis, amino acid metabolism, and they have used methionine as their target molecule that they've studied for a while, but actually the PET is something else which they are studying, and we're hoping that that might be something which we may develop. The advantage with PET is that methionine has got a 20-minute half-life, so you have to generate it in the cyclotron, and needle should be in the patient within 10 minutes or whatever, so you can scan. And because you use a cyclotron for a day to generate it, I don't know, I'm not sure the mechanics of it, but essentially it's a day of the scanner, and you generate that 20-minute sample, and you can line up 2 or 3 patients next door and just give them, within 20 minutes you have to scan 1 or 2 patients with one run. So essentially a day of the scanner you can only do 2 patients. You might be able to do 3 if you get them in and out of the table very efficiently. And we're hoping that in time we might be able to do 2 runs, but this is really, we're talking of getting the process sorted. So you can see why most centers haven't bothered developing it, because cancer will always get the PET scanner priority. Acromegaly will never get a PET scanner priority. So even though Glasgow and other centers could potentially do it, unusually they are happy for Aberdeen to be the center. It would be very rare for Aberdeen to be the referral center for Glasgow and Edinburgh for something like this, which is fine. I mean, I'm happy because that's my area of interest and specialization. So I get referrals for this from the other Scottish centers. But it's really because of the fact that is prioritizing their cancer workload, which is always will be high. So the methionine PET is obviously a tracer which is involved in synthesis of proteins. It crosses the blood-brain barrier and is taken up at the cellular level by amino acid transporters. It's useful in pretty much all the pituitary adenoma subtypes, but it's particularly useful in order galactinomas, TSHomas, acromegaly, Cushing's. So they are the most sensitive in that order. I'm saying from Cambridge experience, I don't necessarily have the data to tell you that. It's easy and fast to perform. Fast because you have to do it in 20 minutes, but then you've used up the scanner for the day. So obviously the cancer specialists will not be happy with endocrine using the scanner for the day. And we have managed to negotiate the use of that scanner for 1 day a month. and that's why we have to select our patients across Scotland to prioritize that 1 day a month, whatever we hopefully will be able to go for 2 to 4 patients eventually. And the bit about the fact is actually it's the co-registration and the software which Cambridge developed, which makes it the utility even better. So they have been working on this for the last 10, 12 years, and they have come up and done some little software modeling and things like that, which they are happy to share with us quite happily. And that's what helped progress things where we are. And there, again, I'm not going to take any discussion about this because it's very technical, but they are able to do even more sophisticated 3D printing of the relevant area, and actually, complex tricky tumors they can actually 3D print and have the surgeon have a look at that in this way, so they can 3D print the tumors. And as I say, we recently discovered a journal called 3D Print Medicine, which is there obviously a growing area, I'm sure, in the coming years. So at our center, the scanner has been available since 2016. I think, Asha, you were there in 2016, isn't it? You were there in 2016 and 2017. So you would have been there for the first few scans done. It's got a sensitivity and specificity about 35% or 85%. And it obviously, the bit which is important is the co-registration of the PET, CT, or MRI. You sort of get a more clear image. Otherwise, if you just do a methionine scan, you'll get a blob, which is, to try and narrow it down, and this thing, that's the co-registration, which is the important bit. So to try and narrow the cases, obviously it's indicated in residual surgery. We would only do it if the patient is going to consider surgery. So there's no point doing it for just academic interest. You would do it if they are going to go for repeat surgery and the target lesion is not identified on conventional imaging. You prepare the patient because you want the tumor to be functionally active. So again, these are things we have learned over our first few images. You want the IGF-1 to be 1.5 times the upper limit to normal. You want the growth hormone to be more than 1.5. Otherwise, if you don't have a functional tumor on the day, the scan is not that active. So you have to wash out the dopamine agonists for a month and the somatostatin analogs for 3 months. Otherwise, you'll do a wasted scan. And we have learned that the scans which have been borderline are because of the IGF-1 was not high enough on the day. So we have to measure the parameters on the day to do that. And then we restart the medication. Sometimes we may wait for the scan, because we can always do another scan quickly. Unfortunately, we will be waiting for the next month, but you can do it if it's just about not that hot yet. So this is the Cambridge experience. Acromegaly. So between 2011 and 2015, they scanned 30 patients with persistent acromegaly. They get referrals from across UK. So this is obviously not, Cambridge doesn't have this much of a population of acromegaly, so they get it across UK for that. So in the background, transmedullary surgery alone in 23 patients, additional radiotherapy in 3, and stereostractic radiosurgery in 1 patient. So the tracer was successful in identifying uptake in 96% of the cases. 25 to 26 cases, we were able to, or rather Cambridge were able to say, this is your spot. This is where the surgeon should go. MRI was obviously unable to. So the added value that the scan gave is quite significant in this group of patients. And then, as I say, what we have learned from our initial things is if you do the scan when the tumor is not functionally active, then you'll get a dubious result. So in the 1 patient that they didn't get a result because somebody had taken out autogel 5 weeks before with that. And similarly, we have had a few results which are not there, and we've realized that the IGF-1 is not high enough on the day. So you want to choose your patients who are poorly controlled with that. So from these 25 patients, I don't have the most up-to-date. This is the publication. They may have done more updates on this, but 14 underwent surgery with a complete resolution in 7 and a marked improvement in 7. So pretty high success rates, 50% cure, 50% improvement which means you can reduce the high cost medications considerably. And then, as I say, 3 received, so 14 went for surgery, 3 received radiosurgery, and that was 2016, whenever they published it. So I don't have the update on what they have had. I'm sure they'll publish in due case. So what about our patients? So my friend from 1997 is now 31 years old in 2017. And he's had acromegaly since 1995. Just summarizing his medications. His MRI had been normal a few times. He was getting a bit fed up with coming, and he's been a bit touchy with that. So we've not really had the greatest control. So we did the scan, and I suppose there was a little bit of a bulky lesion in the pre-pituitary, but we would never convinced him to go for surgery without this showing a really nice hotspot in the pituitary gland. So he had a second surgery, age 31, and post-surgery, he was cured of 45 lakhs of medication annually. He's only 31, he may have lived till 75, 80. So in the single patient, I have saved 10 crores or 20 crores equivalent of money for the endocrine, because we pay for the patient, everything is free. So it would be the NHS which pays for it. So this is his word. I'm so thankful to have lived at a time when so much could be done for my pituitary condition. I can't believe I'm on no medications and I have normal hormonal levels. 23 years after my diagnosis in 1993, he got the year wrong. But he was only 8, so can't blame him for that. And he remains, I saw him just a few weeks ago, he remains cured 5 years on from his surgery. Excellent result. Briefly, our second case, I'm just mentioning it partly because Asha was involved in that case. And this is a girl, young, sort of, I think at her age, yes, she was a 31-year-old woman with acromegaly on somatostatin and dopamine agonists, who had a surgery in 2011, radiotherapy in 2013, and diabetes was poorly controlled. She underwent redo TSS influenced by, before that, actually, this as well. This patient had a pegvisomant allergy. It's the first case report of pegvisomant allergy. And I think the case report is in Jubin. Jubin obviously is the previous fellow before Asha who came from here. So the first case report on pegvisomant allergy is in this patient, and Jubin Jacob was in the authorship of that. So you can see what we showed a hotspot in the cavernous sinus in there. And again, without this, I don't think anybody would have persuaded a surgeon to go in there and try and take out the debulk at least. Amazingly, she also has been cured. 4 years later, she remains cured and off medications. Her diabetes has not been cured, but is substantially improved. So I've been lucky with my first 2 cases. And then a few other cases, I've had reasonable success, but the first 2 cases was enough to tell everybody, look, I've saved quite a lot of money. Let's get this sorted. Let's try and do this. So as I say, in the last 5 years, I have, in these 2 patients alone, saved 2 crores. So we then went about how do we prioritize our group of patients. So we went through a discussion about how do we, prioritize our population, and then in the same way, how do we prioritize, because it's going to be a limited service. And actually, we did a prioritization strategy based on a few parameters. One of the parameters is when do we give pegvisomant? So the Scottish Medicines Authority allows pegvisomant to be used if the patient has got a IGF-1 more than 1.3 times the upper limit of normal on, once the patient's had surgery and, medical therapy with octreotide as well. So that's the threshold we thought is where we would start our first priority group with that. And then, of course, we used a couple of parameters to decide. And we said that that's where we will offer in our patients our first priority. So that instead of going on to pegvisomant, we would do the Methionine PET scan and offer a reoperation. And this is actually the basis of the research we are doing. And one of my registrars actually who just finished a CCT, was awarded the Young Investigator Award in the European Congress of Endocrinology for this project. which is just a proof of concept. So this is essentially our strategy, which we prioritized. We had 1A, 1B, depending on their control. We used control first, then cost, and essentially anybody on somatostatin analog potentially could be eligible. So all the way down to here, you could just, but we don't have the resources to go all the way down to in group 5. We would start with group 1 and work our way down with that. And because NHS is an equitable service, we start in Aberdeen and anybody from Glasgow. So we said that this is something we'll do across Scotland, 5 million population. We should be able to get all our group 1 sorted in maybe in a year or 2. We move down the groups along the way. Interestingly, in the course of our 3 years, we reordered it and we actually had taken away everybody from group 1, which is not just the surgery, because we found, so this is just an example of how we use for prioritization. So this patient, which we did surgery for, would be the category 1A, poor control on highly expensive medications. So it will be at the top of the list for Aberdeen or Scotland. This is an example of somebody else who will be not that high on the list, good control, persistent acromegaly, doesn't like being on medications. So she'll be on the waiting list. So once we have dealt with everybody else, we will offer it to her, maybe in 2025 or whenever our waiting list comes down to that point. So we went through a group of people, and as I say, are targeting it in this strategy for Aberdeen, and then rolling it out across Scotland in the same strategy for that. So there was a big shift in our control, but it's not just the surgical cure, because we discovered this, and it's again proof of concept. I have no idea whether this will be reproducible, but we found that actually taking patients off the octreotide or lanreotide for a period of time, there seemed to have been a tachyphylaxis. Their control improved. So patients who've been on it for a few years, you take them off it and restart it, their control improved. Nobody has done it before, because you wouldn't normally take patients off medical treatment if they're on it. You can't justify taking it off. But because for the scan we did this. So 4 of our patients, their control improved. So this is a poster we put in the European Congress of Endocrinology. And so that's part of the reason why so many of our category 1 had improved, partly because they all improved after a 6-month break while they were waiting for the scan. All their controls improved. We can't do it as a prospective trial, but when we do it in the rollout, we will see if this is reproducible in this thing. But this has not been mentioned before as a possibility. So future directions is to, as I say, roll this out in the same strategy across Scotland and ultimately nationwide, i.e. across UK. So we have this research project we have just started going, and my registrar, who's actually just finished, is ready to be a consultant, is doing a 2-year project on what's called the MORAPT strategy, management of residual recurrent acromegaly following primary therapy, using the PET scan in the management of partially treated and symptomatic acromegaly following primary therapy. So that's acromegaly. So obviously, that's what we are trying to sort of focus on as the high cost, high cure. Going on to some of the rarer tumors, TSHoma obviously is much rarer. So this is another woman who we have been dealing with for the last 10 years now. So she presented in 2010 with discordant thyroid functions, heterophil antibody tested negative. We did the genetic panel for thyroid hormone resistance negative. She had a TRH flat response, so suggestive of this thing. And her pituitary MRIs were normal on multiple occasions. So clearly the key differential is it resistant to thyroid hormones or is it a TSHoma? So these are the sort of parameters which can help between the two. They are obviously all rare situations. And in her case, we were fairly convinced. And the other factor which I will draw your attention to is the Dept SSA response. So we started her on lanreotide and she responded. So we were fairly convinced it's a TSHoma, but we couldn't see it. So Cambridge, and this is I think the first case in the world that they had done this for, they localized an occult pituitary, a very similar case to ours, by doing the scan and still not convinced. So they did what's called a subtraction scan. They gave a bit of time with the, so they did a scan before somatostatin analog. On somatostatin analog, you can see that activity was suppressed. Off, so they did it on and off 3 times. We can't afford to do that. That's 3 months of scans done. We can't afford to do that. But they did it, and they proved that this is the active bit. Again, nothing to be seen, but sufficient for them to recommend, the neurosurgeon go in and have a go, and they cured it. So our patient was very similar. So this is probably the second or third case in the world that this was done for, where good response to lanreotide. We took off SSA, and you can see the T4 and T3 went up, as you would expect. So she was active at the time of the scan, and then we put back good response with that. So this is her scan. So a couple of plots, the surgeons were not absolutely convinced that they can go for it. Cambridge did more of their subtraction and whatever analysis that they did, and they gave it sufficient confidence that there is a central spot. So our neurosurgeon, we said, let's take a leap, let's take a leap and go for it. We went ahead, August 2019, she had a transsphenoid surgery. A grayish pink adenoma was seen bulging into the adenoma was resected, cured. So again, many years of somatostatin analog, costing 12 lakhs a year or whatever, thereabouts. November 2017, and then 20 months post-op, February 21, I have now data a year later on as well. She remains cured. So excellent result, a micro TSHoma that we would never have considered going for surgery without that. So I think Cambridge have done about 5 to 8 cases now over the time since then. But yeah, it's still very few cases done worldwide of the scan. It's used in Cushing's. Obviously, Cushing's, this is the diagnostic pathway. We first of all prove Cushing's syndrome, and followed by that you do various methods to try and confirm that it is in the pituitary. And not the challenges between pituitary Cushing's as ectopic, and the tests which help are the high dose test, the CRH test, the desmopressin test, and or BIPs. So that's where the challenge is, to try and identify these two. So the Endocrine Society guide, if a lesion is less than 6 millimeters, you want to have something more supportive to convince you. Most pituitary experts now don't do the high dose dexamethasone suppression test. They say it's least useful in differentiation. And the tests that we do are now the CRH test and the vasopressin test. These are the tests that we would do. The BIPs, obviously, now that we have the scanner, I would not do this on anybody else, because I'm convinced the scanner is going to be more sensitive than sending somebody for an invasive BIPs for that. And obviously, you're doing a scan chest and adrenal to make sure there's not ectopic. So bilateral inferior petrosal sinus sampling has got a good sensitivity and specificity for localizing it to the pituitary, but it's not that good at localizing left or right. So in effect, the BIPs is better useful to tell you that this is a pituitary lesion rather than saying this left or right. So this is a non-invasive strategy recommended in JCEM, saying that if you combine 2 tests, the CRH and the vasopressin tests, they have a 73% sensitivity and a 98% positive predictive value for Cushing's. And if you do it to the negative scans as well, is approaching in their series of about 167 patients with Cushing's and 27 with ectopic. So we have, in the period of time that we have not had the scanner, we have not had the scanner for the last couple of years. I've done this combination. So I've still not sent anybody for BIPs in the last few years. I've done this combination of tests and been convinced and sent for surgery directly and have a successful result. So that's the approach we would be taking now for these patients. So the Cambridge experience in the Methionine PET for Cushing's, they have studied 20 patients between 2010 and 2015. Cushing's de novo in 10, MRI positive in 6. Residual or recurrent hypercortisol following first surgery in 8, MRI positive in 5, ectopic in 4. So their experience versus the BIPs, obviously these are small numbers, not enough to say that this is far superior to BIPs. But in these 6 cases, in 3 cases, the lateralization agreed with the scan. In 3 cases, it disagreed with the scan. The surgeon went with the scan rather than the BIPs, and the surgeon was, as I say, the scan was proved correct in all these cases. So it seems that PET scan is superior to BIPs in lateralization. But as I say, we think that the BIPs is mainly useful to say it's pituitary, and therefore you really don't need to do a BIPs. You can do the non-invasive strategies. All it's going to tell you is pituitary, then the non-invasive strategies is probably there with that. So our experience with Cushing's. So we have this 67-year-old woman, Cushing's syndrome, admitted with psychosis in 2015. This is actually a Dundee case, so it's a rough referral rather than our own patient. She had a right adrenectomy for a 4-centimeter mass. She went on to be proved to have ACTH-dependent Cushing syndrome. BIPs, CRH test was suggestive. BIPs was suggestive but couldn't localize, but they're still not absolutely happy. 2 MRIs negative. Urinary free cortisol elevated. ACTH not suppressed. MRIs, nothing to be convinced, but I mean, there's some sort of there, but certainly nothing that the surgeon would go for. And on the scan, the PET scan showed this lesion here. She went in for surgery and again has been cured. So, as I say, I might be just lucky, and we may not reproduce the results when you do across Scotland. But in our hands, we've had extremely good results in the cases we have chosen to do it. This is a patient from Inverness. So again, a referral from the Highlands, 28-year-old man with ACTH-dependent Cushing, secondary to a pituitary macroadenoma, diabetic on metformin, insulin, and exenatide. She had first surgery and 6 months post-op still had problems. So recurrent Cushing's. So what are the options for recurrent Cushing's? First of all, it is a fairly frequent occurrence. In about 15% of patients, the recurrence will be there. And recurrence can be as far as several years down the line with it. Though 50% of relapses really occur in the first few years. So the options are going for a second or third surgery. Success rates are about 60%. Recurrence still possible. Radiation with the downside of being hypopituitary. Success rates are between 40 to 70%. Medical therapy. Success rates, again, about 60%. There are new agents available, obviously, these oscillodostrat and things like that, which are now coming in and being touted as. And of course, adrenectomy, where there's a 100% chance of cure, but lifelong risk of lifelong adrenal insufficiency, risk of Nelson's, etc. So you have to weigh these pros and cons with that. So in our patient, we did this scan and we saw this. Obviously, there was a residual lesion, but whether it's residual tumor, active or not, this helped us confirm it. Showed this is a spot in the cavernous sinus. The surgeon went in, had an improvement. So it was okay for a few years. So we've not had a 100% success rate. And we are currently waiting to do another scan and decide whether to consider bilateral adrenectomy or whether to go for targeted radiotherapy. But we are waiting for another scan to make that decision because he's only 20 years old. So we have not yet made that decision. He's currently controlled on metyrapone at the moment. So there was a partial success. So this is not a cure. This was a partial success. But I mean, I'm sure Prabhu will agree. It was fairly into the cavernous sinus. Is a fairly brave surgeon to say I'll go for it anyway in that point and try and clear it. So that was the outcome of that. So these are obviously the options again that we talked about, and we went for it. And we're discussing whether to go for bilateral adrenectomy or go for radiotherapy. I don't think we'll go for a third surgery, probably radiotherapy. So we will decide if we see it on the next scan what the hotspot is, because radiosurgery, again, targeted radiosurgery, less chance of hypopituitarism and other problems. So that's really our summary of experience in acromegaly, telangiectasia, and Cushing's. And I say we may be just lucky in having a pretty good experience in the first few, but Cambridge have had a reasonable success rates as well. When we roll it across Scotland, there'll be more variables. There'll be more surgeons doing it, not just one surgeon. So that variable comes into picture as well. But time will tell whether this is something which, well, I certainly think it's been transformative for the cases we have done it. Availability, cost, all of those things which factor how widely available it becomes. Thank you for your attention.
Thank you, Prakash, for that absolutely world-class talk. In fact, I think I need to admire Prakash. He's had these abilities for the last 35 years. You can see, besides being an endocrinologist, and of course his wife is a pediatric neurologist, which also bears some similarities. He's actually got some amazing organizational, so to get the PET scan and the isotope done in Scotland is obviously no mean feat. So, and once again, of course, we are looking forward to the future, and Julie has assured us with surety that within 2 years, we'll be having the cyclotron over here, and we'll be hopefully trying to get experience from you and tips on how to actually make this a success. Anyway, over to the house for questions from the floor. I think the neurosurgeons would be curious to know, because you probably also have a very precise neurosurgeon sitting out there as well, which
that's the key, isn't it? There's no, I mean, obviously the neurosurgeon is the one. This is just a hotspot, identifier, but the neurosurgeon is the one who has to go and do it. Yeah.
I have two questions. One is, you mentioned about this, the IGF being measuring on the same day.
Yeah.
I think that's one.
So you want to make sure the tumor is functionally active on the day of the scan, because if it's not functionally active, you have to interpret the hotspot with the functional activity. So if IGF-1 is 1.3, it may not be as active. So the IGF-1, I'm not saying not necessarily on the day, but around this 3-4 days, that week, because if somebody's IGF-1 is 3 times upper limit normal, you know you're okay. But if IGF-1 is just 1.6, 1.7, it is useful to make a decision on whether you want to rescan, because you can't justify rescanning if IGF-1 was 1.6 a month ago, and you have to interpret it, you need to have both, and that is true for Cushing's as well. So you do you want to test the 24-hour UFC in that sort of window of the time that you're doing it, and we are discussing whether things like using a CRH test will improve the specificity, and sensitivity of it. So those are things which there's not enough Cushing's to do that sort of study, but we are in discussion with Cambridge to try and see once we roll it across Scotland, if you get enough referrals, we might just try a few. But the numbers are never going to be enough to give a statistically significant this thing for it. But those are things we're exploring. Yes.
The second question I have is in relation to silent corticosteroids.
Yes.
We find that some of them, you exercise it and they just remain dormant, they don't grow back. But some come back within a year or two, they grow back. So do you think there is much bigger role in silent corticotroph adenomas? I don't think there's no question about it.
Yeah.
But I'm looking at the bigger picture, more numbers of silent corticotrophs.
Yeah.
Which do you think has got a bigger role in the future? And if we should do that, those patients,
Well,
methionine?
I think we don't have enough experience with it. We might do it once we are doing it. Also, which this thing, when that comes, will probably be more superior. So once we can get the.
You see that number is actually a larger number.
Yeah, I agree. Yeah.
740 is much larger than the Cushing's or Ractamel.
Yeah.
That number is huge.
Yeah. So the gallium CRH, if it becomes, by the time if it takes off in at least 1 or 2 centers, then I think that might be the thing with that. But yes, Cambridge can do it even for non-functioning. Even non-functioning is they do it. So it is useful across the spectrum. But I think my biggest bang for the buck has been in these functioning tumors, where I can prove quite a significant change in the well-being and targeting it.
But then the non-functioning itself is a misnomer.
Yeah.
I mean, in the sense
they have different.
Now more and more.
Yeah.
Silent corticotrophs, lactotrophs.
Yeah.
You're finding more and more pathologists are finding.
Yeah.
Yeah, the question, Asha, would you like to say something?
Of late, we are finding a few whispering adenomas, where the growth hormone is just mildly elevated, not very classical. Similarly, mild Cushingoid plus minus maybe. So we don't know the utility in such kind of patients.
I don't think you will find it there, because it has to be, it has to be functioning to do that. So I don't think you will get it. I think this is the same thing. I mean, TSHomas, micro TSHomas was identified as an entity only in the last few. You say TSHoma, it would be a macroadenoma, which we always have. I have about 3 or 4 micro TSHomas in Aberdeen. I'm not talking of in Scotland. I have 3 or 4 micro TSHomas in my patch of 500,000 people. So it's more common than, because the testing is done so often now that we're finding these discordant thyroid functions and test for that.
I have 2 questions. So you said you don't have much experience with gallium rota scans. Anything specific and it's much easier.
So in Scotland, each center has license for certain things. So we have this carbon license, and therefore we can do Aberdeen. And that's one of the reasons as well why we could do this, because it's a 11C. So we have the 11C license. Well, having said that, we have the gallium scan now. We've got, with the new cyclotron, we have got a bigger set of abilities to do it. But before, just like Aberdeen is the Methionine scan center, Glasgow or Dundee or whatever would be the gallium scans. So if it's not available, I won't do, I'm not going to send patients to Glasgow if I don't think it's going to increase my utility. So I don't have that much experience in gallium. However, we do have the gallium dotatate available soon. So
the reason why Prakash is mentioning is remember that most of the healthcare in UK is government covered. And so it's actually very cost effective to have areas of focus for various, unlike how India seems to be very private driven in how it actually functions.
Yeah, so we would have one. So we have for the parathyroid tumors, the choline PET is fantastic. So we have agreed that Edinburgh will be the center for choline PET. So we've sort of distributed the expertise and things across the centers a little bit.
So the second question is, a hybrid PET MR, or is it's a co-registered separate MR and separate PET?
So what we have is separate at the moment. I think Cambridge have that there, but we have a separate. I think if you're doing it new, you probably think of all these things, but at the moment no.
One suggestion, just a comment. Contrary to what we all think, that methionine PET is not available in India, it's actually available in few of the centers which have cyclotron.
Yeah.
So there are centers which have experience in methionine PET in pituitary tumors and other prostate malignancies.
Yeah.
Yes,
but I think this co-registration and this thing is probably what gives you the added value of that. Yeah. So yes, methionine is available certainly in other.
So without mentioning names, the centers which have cyclotrons are largely with the government. Am I right in saying that, or are there private centers which also have? There's no private center which has a cyclotron at the moment. Are private centers. Okay. Any questions, postgraduates,
So the images which you had shown, the hotspot was being picked up in the lesion which was seen on the MRI. In some effect, you could make out that part on the GADO MRI was a little hypo-intense. So if the lesion can be seen on an MRI and it is being picked up on the hotspot, so how does it kind of help a surgeon? I think it should help more if you're planning for a radiation or something. What do you comment with that?
So two things. One, particularly recurrent surgery, you need to have a little bit more evidence to say, convince the patient to go for it. So particularly in Scotland, where patient choice and all that comes into it, the cost doesn't come into it. 45 lakhs a year, no problem. I'm not going for surgery, sir. That doesn't come into it. You have to convince the patient. So the hotspot changes that discussion. Second thing is many of them are micros. So microtears, that surgeon is not, because you're not sure if it's residual remnant, just a little bit of post-operative surgery. Maybe the fat pad that the surgeon is putting or whatever they put into to plug the leaks. So all of these could be a little bit of that, bits that you see or hypotense there. So the hotspot certainly is what convinces you of the functioning aspect of it.
Let me just rephrase that question, sir. Question is, when you see the hotspot, why are they going for surgery and not for focused radiation?
So if you can access it by surgery, surgery is always the first choice. If you can't access it, if it's in the cavernous sinus or something like that, then radiosurgery. But if the surgeon feels like, because one is cure is quicker, cure is immediate. Two, there is a less risk of subsequent radiation-related hypopituitarism, stroke, everything else that radiation brings along with it. So if the surgeon says that I can go for it, surgery is always the first choice.
Thank you once again. That was an amazing talk, and thank you for the wonderful questions that you've asked. Let's give Dr. Prakash for coming all the way from Scotland. And as you know, Scotland is an oil-rich country, and perhaps will be the light of Europe very soon. Thank you so much.
Thank you. Thanks.
Good.